So good evening, everybody. We will not waste much time. The importance of today's meeting, this meeting is being organized by IMA College of General Practitioners as well as the Public Health Committee of IMA KSP. Recently, this is a time of epidemic as far as Kerala is concerned. During the start of monsoon, we used to get many epidemics. And this time there is emerging epidemics like Shigella is coming from reporter from Wayanad. Cholera, suspected cholera cases are being reported from Palakkad side, and we have Nipah reported from Calicut itself, re-emergence of this infection. So we have already various infections already endemic in our place, but there are new certain epidemics are emerging for the last few years, and every year now we are seeing separate diseases coming up. So we have jointly organized this meeting to make our own members aware, and subsequently we will be taking it to the public at large. So our state president, Dr. Menon sir, had consented to inaugurate this meeting. I hope sir has joined. Dr. Prashant is already here. He is the chairman of CGP. So Menon sir, are you there?
Yeah, I'm here.
I request our honorable state president, beloved state president, to inaugurate this program. We will be taking up this public health committee and CGPs and empowering our general practitioners and physicians. And now public health committee will try to take this to the public also with guideline for public in view of the emerging health. After I request Dr. M. Menon sir to a few words and to inaugurate this program. Good evening, sir. Welcome.
Yeah. Good evening, Chairman Dr. Pradeep, Dr. Altaf, Dr. Aravind, Prashant, Bhavredra sir, Surufi, other senior leaders, National Vice President Dr. Ramesh is here, other senior leaders and friends. Very good evening. It's good that the Public Health Committee has taken up the initiative to come out with a webinar on emerging infections. In fact, this is the time we have to be alert and update our own members on the various infections, because the fever has started, season has started. It has been, as already pointed out, Nipah has been identified somewhere. COVID-19 is here. COVID-19 is here. Then the West Nile fever, dengue, of course. Shigella has been reported, and H1N1, even chikungunya, amoebic encephalitis was there. So a lot of issues we are facing, and I think IMA being the flag bearers of the medical fraternity, it is our responsibility to look into these matters on an urgent basis and come out with scientific guidelines for the public and even advices to the government. And I think this session will be a very important milestone, and Dr. Pradeep and committee will take up this seriously. And the AMS chairperson also here, I think Dr. Deepa, the CG, our academic wings are here. And I think in a combined way, you have to think about these things and come out with definite plans. So let this be a first step so that we can plan. Dr. Altaf is there to help, and a lot of others could contribute. So I think I don't want to prolong my talk here, because more important is the sessions by the experts, Dr. Aravind and Dr. Altaf. I wish the program all the best. It will be a fruitful session, I'm sure. And officially I declare that this webinar is inaugurated. Thank you. Jai Hind, Jai IMA.
Thank you, sir, for your presence and valuable time. I request National Vice President Dr. R. Ramesh sir to give a few words.
Thank you, Dr. Pradeep, respected senior leaders and friends. I too don't want to speak early so much, because I think the most important is the sessions by two very good experts, Dr. Aravind and Dr. Altaf. I'll take just a minute saying that IMA has a big role in this situation of emerging and re-emerging fevers. We always see over the years that during the pre-monsoon and during the monsoon period, we have certain infectious disease issues in our state. I think the role of IMA has to be in three ways. One is, of course, to train our doctors for the early diagnosis and proper management of these infections, and also coordinate with the private sector in proper reporting, and to have a good reporting system. And another area where IMA can step in is creating real scientific awareness, because I always mention that scientific awareness, because we as a professional body, we have experts we can give authentic awareness sessions for the public, what to do for preventing. The prevention aspect is very important, as well as if, unfortunately, they get an infection, what should they do immediately to approach a modern medicine doctor and or the nearest healthcare institution so that they get the proper and early treatment. And the third thing is, of course, to liaison with the government in the policy matters. Yeah, we need, I think, we have learned in our community medicine, prevention is better than cure. We still need to do a lot of work in the preventive aspects because we have been seeing this trend for the last so many years. So we need to do certain research activities as well as think more about the what more we need to do for the prevention of such infections. For that, I think there has to be the government which has brought out the One Health policy. I think IMA has to work on it, and that One Health policy has to be implemented properly. That means the coordination of various departments and the public, as well as all the stakeholders. And I think we should be able to find out a way for this. Otherwise, every year at this time, we will be discussing the same thing. And I'm sure there is sessions conducted by the IMA with the IMA CGP, the IMA Public Health Committee led by Dr. Pradeep, and ably supported by the state headquarters will definitely be useful for the doctors as well as for their meaningful impact on the community health as such. And I'm very sure the sessions by Dr. Altaf as well as Dr. Aravind, who are well-known experts in this field, will definitely throw more light on all the aspects of the topic, and will be a good learning experience for all of us. Thank you. Wishing you all the best.
Thank you, sir. Thank you for your words. And I request Dr. Babu sir to say a few words.
Thank you, Dr. Pradeep, respected President, the senior members, and my dear friends. So I should congratulate our academic wings and the Public Health Committee headed by Dr. Pradeep Kumar for this initiative. And now we have so many new infections re-emerging, emerging, and confusing in the society. It is imperative that we should educate our members, upgrade them with recent information. So I'm very happy that you have come forward with that venture with a very excellent speakers, Dr. Altaf and Aravind. And I'm sure that the message should go to all members so that the participation will be effective. Your work should be properly rewarded. Though. When the more members participate, then only it will be useful. Anyway, congratulate Dr. Pradeep and our academic leaders for the good venture and wish the deliberation all success. Wish you all the best. Thank you, Dr. Pradeep.
Thank you, sir. Thank you, sir. Thank you for your words. Dr. Sulfi, sir.
Yeah, Dr. Pradeep, Dr. Aravind, Dr. Baburi Vidin sir, and Dr. Prashant and all. This is a very important initiative by Indian Medical Association because we know that during the COVID era, we've been discussing this public health issue, the COVID issue, and all other issues in an elaborate way. We used to discuss these things with all the public health experts and the clinical experts regarding COVID-19, and government was actually, in fact, it was the government was forced to follow the directives of Indian Medical Association in some way or other. So maybe we are discussing these issues in an elaborate way, and that is helping the public health aspect as well. So this is a very good initiative, and I think we can contribute by forming policies and also by discussing among our colleagues and our experts. So all the very best to the initiative. I congratulate Dr. V.G. Pradeep Kumar and also Dr. Prashant CV and Dr. Altaf and all others for taking up this initiative. All the best for the project.
Thank you, Dr. Sulfi. Dr. Roy Chandran, State Secretary. After that, Dr. Prashant will take over for the sessions. Dr. Roy? I request Dr. Prashant, the chairman of CGP, to give his few words as well as to then start the proceedings with the speakers. Dr. Prashant, please.
Thank you, Dr. Pradeep, sir. Respected leaders and dear friends, it is indeed with a great pleasure I am, talking to you right now for a few seconds. See, the Indian Medical Association College of General Practitioners is extremely happy to join hands with the IMA Committee of Public Health to discuss this topic, particularly in this angle, emerging fevers and, evolving solutions. See, as the frontline warriors of modern medicine, we need to evolve solutions, whatever be the problems, whatever be the crisis that we face. So in this moment, we are blessed with two faculties, Dr. Altaf, who is a professor of community medicine and an icon of public health in India, I should say, and then Dr. Arvindar, who is a state nodal officer for the all infectious diseases and emerging infections and all. And just before going to the program proper, let me remind you all, please share this Zoom ID, password and link to every doctor of modern medicine, because every Thursday at 8 p.m. IMA CGP is coming out with all currently relevant topics, and we'll be discussing the topic in pure academic sense. So with that introduction, let me proudly invite Dr. Altaf and Dr. Arvind for the sessions, and please make use of this. And let me also tell you that this program is getting live streamed in the YouTube, so that everyone can access to the YouTube later on too. But in this Zoom arena, you can have interaction at the end of the program. So let us first go to Dr. Altaf, who is also the convener of the Public Health Committee of IMA, and who is a veteran. Whenever there is a crisis, Altaf comes with a clarity of vision and comes with a formula of action. And so I am so delighted to invite Professor Dr. Altaf for his session. Dr. Altaf? I think there is a technical problem there. We'll start with the Dr. Arvind and then come to Altaf. Dr. Arvindar, who is another an icon of ID. Whenever we have a crisis in any infectious disease, we have only one name. That is none other than Dr. Arvind. And we are extremely proud of this great physician and a leader of Indian Medical Association. And he is always there wherever there is, IMA for, linking the system, the government system as well as the private system with the knowledge of the current era and even knowledge of the future, right? He's a visionary leader of our profession. Let me welcome Dr. Arvindar for his talk.
Thank you, Prashant sir, for the kind words. Also, I would like to thank Menon sir, Ramesh sir, Prashant sir, Pradeep sir, Sulfi sir, and all senior leaders of IMA for giving me this opportunity. So I'll start sharing the slides. Sir, are the slides visible now? Prashant sir, are the slides visible?
Yes.
So the topic for the day is emerging fevers and evolving solutions, and I will take you through the clinical perspective. So like what we should be taking care in the hospital scenario, and the public health aspect, etc., will be dealt with by Altaf sir. So why we should be very careful while dealing with, sir, I have gone to the second slide, right, sir? Now?
Yes.
So why we should be careful of emerging infections like, say, Nipah or Ebola is because of the health concerns. Sister Lenny is familiar to all of us, and the other doctor is Dr. Carlo Arbani, the WHO doctor who identified the index case of SARS in 2003, and unfortunately he also succumbed to the disease. So this is the problem with almost all the emerging infections like, say, Nipah, Ebola, Marburg, Crimean Congo hemorrhagic fever, etc. Because if you are not sticking on to the standard precautions and transmission-based precautions, we know that in our busy hospitals, etc., it may not be always be possible to adopt all the standard precautions. But in certain cases, the diagnosis might come, say, after 3 or 4 days, and we get exposed to these sort of serious pathogens. So that is the importance of emerging infections. And our health is in our hands. So the most important aspect is like, if you want to identify these emerging infections, we need to test them. So most of them, like, may not be covered by the usual battery of tests. We may have to order a specific tests like, like in Nipah and all, Nipah PCR, Ebola PCR, even in the current the outbreak of Shigella. So usually in our convention is that, Shigella will present like a dysentery, there is blood in stools. We have studies from Calicut Medical College showing that even in patients with severe Shigella encephalopathy and all, maybe around 10-15% only are having blood in stools, and a majority of them are diagnosed not by the stool culture, by stool PCR. That clearly shows that the clinical acumen is necessary to order the right test to diagnose the emerging infections. So these are the steps that we need to keep in mind while approaching any case of fever, like the geographical location. That's actually very important. This epidemiology. Then the seasonal trends. The best example is Nipah. So we'll be expecting Nipah from May to September in Kerala. And in, say, Nilambur area, etc., Wayanad, Malappuram area, Nilambur area. So from December to May, we should be expecting Casimir forest disease. That is the period during which we have the maximal nymphal activity. The occupational exposure is also very important, like certain professions, like, we know that farmers and NREGA workers, they have increased risk of, or any manual laborer has an increased risk of getting leptospirosis, farmers, butchers, etc., increased risk of getting melioidosis, etc. The travel history in the current context, I'm not going to spend much time on travel history. Everyone knows the importance of that. The exposure to animal and vectors also very important. Food and water exposure. If you look at, what has been happening in Kerala over the last 3 years or so, all the waterborne infections are speaking like anything. So hepatitis A outbreaks we are having, the endemic fever is on the rise. The Shigella is also a food and waterborne disease. So, that means that our water quality has gone for a toss. Then the contact history is very, very important aspect, as well as the host-related risk factors. Host-related risk factors means all the emerging infections, like any infection, it tends to have a very bad outcome in immunocompromised as well as in extremes of age. So, and based on this, the pointers from the history and the clinical examination findings, we need to pick the right test to identify the emerging infection. So I'm going to take you through some the scenarios which we face day in and day out in majority of the tertiary care centers in our state. So, 28-year-old gentleman hailing from Bangalore has presented with fever, headache, myalgia, fatigability, diarrhea, and rash of 2 days duration. He had arrived at Kochi airport from Nigeria 1 day back, employed as a staff nurse at Nigeria. So what should the emergency doctor do? So these are scenarios like this. This is a person who is coming back from an African country, and he's having the symptoms of say fever, diarrhea, rash, you can say, maybe the early symptoms of a hemorrhagic fever sort of thing. Then the diagnosis actually can come later. It could be, say, it could be a dengue, or it could be Lassa fever, whatever it is. The most important thing is when such a patient is reaching any of our hospitals, right from the casualty itself, we should be able to pick these sort of patients and quarantine them. So basically, we need to activate the red channel, isolate the patient, inform the hospital infection control team, inform the district surveillance officer. And most important thing is that, we have to ensure that all our frontline workers in the ER should be using the proper, the PPE they are supposed to use. PPE does not mean, putting on all the coveralls, etc. PPE in the ER means actually using the triple layer mask always. That is adjusting the mask from chin to nose. It's very important. And another important aspect is that when we hear about Ebola or Marburg, etc., we think that these sort of things are happening in distant places. But obviously, Kerala is connected with almost all corners of the world. So any infection anywhere can reach Kerala within, say, 24 hours. And we need to have this sort of an approach, better safe than sorry approach. So last week, we had a patient, a 28-year-old gentleman hailing from Kollam, and he had reached Kerala from Burkina Faso. It's an African country, it's a neighboring country to Nigeria. On 30/5/26, he had presented with, he developed fever, myalgia, chills, excessive fatigability, and yellowish discoloration of urine 3 days after reaching Kerala. So he was referred from to GMC from District Hospital Kollam. There, he was admitted with these sort of symptoms, and investigation had shown hepatitis. You can see the SGOT and SGPTs were very high, and INR was 1.7. So the patient was actually, the DSO from Kollam contacted us and was actually referred to Medi College. And since, the patient is from Africa. Even though Burkina Faso does not come under a country where the outbreak of Ebola is going on, but still there are other infections which are going on. They are like, say, yellow fever, or say Crimean Congo hemorrhagic fever, falciparum malaria, Lassa fever, etc. So Lassa fever, yellow fever, etc. means that we need to be very, very careful. So the same the scenario was enacted. That is, this patient was taken through the red channel to the isolation ICU, and these were the DDs we considered: that's falciparum malaria, Ebola virus disease, yellow fever, CCHF, Lassa fever. And the next one is YEL AVD is that, this person had taken this yellow fever vaccine in 2009. So there is a possibility of a viscerotropic disease following this yellow fever vaccine. That is known as yellow fever viscerotropic disease associated, yellow fever vaccine associated viscerotropic disease. Then there is a hepatitis C outbreak going on in Burkina Faso, as well as a hepatitis A outbreak. So falciparum malaria was ruled out. Ebola virus actually does not come under the the strict definition, because the patient is not coming from this Congo, Sudan, or Uganda. But still, since the patient is having features or liver failure, etc., we decided to rule out Ebola as well. Yellow fever, he had been taken vaccine for against yellow fever in 2019. But still, we consider, because he is coming from an yellow fever endemic country, so we just adopted the better safe than sorry approach. CCHF, is also a hemorrhagic fever, where the healthcare workers can also get affected if we are not strong with our standard precautions, and mortality is 30%. Lassa fever is endemic in this area, etc. And yellow fever associated viscerotropic disease usually occurs within, say, 1 to 2 weeks of developing the yellow fever vaccine. So that is out. Hepatitis C and A has to be ruled out, and this patient was isolated, and all the samples were sent, and this turned out to be a case of hepatitis A. And then all the isolation precautions were, actually withdrawn. But it could have been a case of this Lassa fever, or this yellow fever as well. So that is, how we should be approaching all these emerging infections. And then we should know about the transmission dynamics of infections like Ebola, this Nipah, etc. For example, this is with regard to Ebola. In a case of probable or confirmed case of Ebola virus disease, who is at maximum risk of getting infected? So one thing which Ebola shares with Nipah is that the maximum transmission occurs when the patient is maximally symptomatic. That is by around day 4 to 6. So there is no pre-symptomatic transmission in case of Ebola or, say, the Nipah virus disease. And that is the reason why the people who are at maximum risk of getting, say, Ebola, or, say, for that matter, Nipah virus infection, are healthcare workers in the ICU. Because when the patient is maximally infective, the patient will be having ARDS and all those symptoms. And in Kerala, where the health-seeking behavior is very high, at that time the patient will be in our ICUs. And that is the reason why, we should be very strong with our IPC practices in our ICUs. And we know that Nipah, the droplet transmission, occurs only when the patient is having an ARDS or pneumonia-like presentation. Usually in encephalitis, we are not having a droplet-based spread in Nipah. But the problem is that in ICU, we may end up doing aerosol-generating procedures like intubation, bronchoscopy, NIV, tracheostomy, etc., where, even Nipah can become an airborne sort of this thing, because we are doing aerosol-generating procedures. So in case of any patient in the ICU without a diagnosis, whenever doing an aerosol generating procedure, it will be prudent for us to ensure that we are wearing N95 mask. Then this is the key learning that we had from, say, the 2018 outbreak of Nipah, where there is the transmission occurred within the hospital environment. So there, the index case happened to have this ARDS pneumonia plus encephalitis sort of presentation, and you can see the transmission which occurred to the other patients in the wards as well as the ICU. So this is something that we need to prevent. So in Nipah as well, a patient who is presenting with an ARDS sort of scenario, we should be very, very careful with regard to our standard as well as transmission-based precaution. But the problem here is that the patient is not going to say that I am having Nipah, right? So any patient who is presenting with ARDS or encephalitis in Nipah endemic areas, we should be having a suspicion of the Nipah virus also. And this is the most important aspect. If you are able to pick up the first case of an emerging infection at the earliest, the opportunity for control is going to be very high. So if it is detected late, it will actually result in transmission. In that process, healthcare workers also can get infected. So basically, our aim must be to detect all these emerging infections at the earliest using the molecular tools, so that the opportunity for controlling this is maximal. why standard precautions really matter and why we never learn. So, in a state like Kerala, especially in the North Kerala, where we have been having, say, this is the 11th outbreak of Nipah in our state. So we have been having outbreaks, so spillover events, almost every year from 2018 onwards. But still, when we do this, when we look at the CCTV images, we are surprised to find that even doctors who are intubating the patients, etc., sometimes the mask is not really on the nose. So it's an alarming scenario. So this happened maybe around 2 years back. A 16-year-old girl, fever, headache, cough for 4 days duration, palpitation. She developed palpitation, hypotension. She was suspect of having a viral myocarditis with ARDS, admitted in a cardiology ICU because had gone to a tertiary care, a private hospital, had myocarditis with ARDS and was admitted in a cardiology ICU, developed MORS, intubated and mechanically ventilated. And since the treating doctors suspected poisoning as well, a medical legal autopsy was performed at Kozhikode MCH. But in Kozhikode MCH, any patient who present with ARDS, myocarditis, etc., they do this Nipah testing as well. And the diagnosis turned out to be Nipah. So this clearly shows that usually we expect the Nipah to present as encephalitis, where the patient might go into medicine ICU or say a neurology ICU or as an ARDS sort of presentation. But Nipah can end up in cardiology ICU as well. So that is the importance of actually sticking on to our standard precautions as well as transmission-based precautions. Having said that, Nipah can present as an ARDS sort of scenario, can present as an encephalitis sort of scenario. And we know that in Bangladesh, where every year the spillover around 6 to 8 cases are diagnosed. So if you test around 1,000 cases of encephalitis, even one may not turn out to be Nipah virus encephalitis. So that is like, if you're looking at emerging infections, it will be like searching for a needle in a haystack sort of scenario. So, and WHO till 2024 used to publish a list of infections, 10 top priority infections for which we do not have an effective vaccine or effective treatment. So, and from 2024 onwards, they changed this to the families of viruses, etc. So, if you are looking at the diseases for which we don't have an effective vaccine or effective treatment, the first 4 happens to be hemorrhagic fevers like the CCHF, Ebola, Marburg, Lassa fever. Then the next 2 are the respiratory viruses, that is MERS and SARS. Then comes Nipah, Rift Valley fever, then disease X. Disease X is an unknown pathogen, is likely to be a zoonotic pathogen, which at any point might spill over to the humans. The interesting aspect is that, the small terrain of Kerala has actually reported the 4 of these emerging infections. That is CCHF, we had an imported case that is, was not diagnosed here. A diagnosed case was treated in Kerala around 45 years back. The patient had acquired the infection from Middle East. The Nipah, we are reporting Nipah, we have Zika as well. So Kerala, is in the top list of areas where emerging infections are there. Our aim must be to have a framework to identify emerging and re-emerging infections at the earliest so that we can institute optimal IPC measures without delay. We should have effective triaging facilities in the casualty to optimize IPC measures with regard to standard and transmission-based precautions. And we need to have the framework of rapid diagnosis through multiplex PCR platform to identify these emerging infections at the earliest. And in cases of deaths, especially without the reason, the pathological autopsy must be performed for diagnostic purpose. So in 2018, in all the medical colleges, we started this outbreak monitoring unit for this purpose, so that we can identify these emerging infections at the earliest. So basically, we are focusing on if there is a history of zoonotic contact or clustering of cases in the family or locality, travel to forest areas, or fever death without a diagnosis in immunocompetent patients. This is the basic algorithm. So usually these emerging infections can present as a severe pneumonia, ARDS sort of thing, like our this influenzas or the SARS-CoV-2, the MERS also present like that. Hemorrhagic rash. So, the Ebola, the Marburg, Lassa fever, etc., presents as hemorrhagic rash. Meningoencephalitis, we know that Nipah, this Centra virus, etc., and amoebic meningoencephalitis, all these things will come here. The severe gastroenteritis. Severe gastroenteritis means some of the hemorrhagic fevers like Ebola can present as severe gastroenteritis, or Shigella also will come here. Then acute liver failure. Acute liver failure, why we kept it is that at any point of time, there is a possibility that yellow fever can get imported to Kerala. So what we do is that if any patient is presenting with these features, So we'll try to rule out the usual suspects like, say, leptospirosis, dengue, the enteric fever, the scrub typhus infection, etc. And if we are not able to come to a diagnosis, then using the multiplex PCR platforms and all, we'll try to come to identify the emerging infection. So one example, this is in 2018, this lady had come to us from Qatar, and she had presented with a history of influenza-like illness and later developed pneumonia and breathlessness. So basically, she presented with SARI-like features. So these were the differentials entertained. So any lady who is coming with ILI SARI, the influenza A, B, Mycoplasma, Legionella, Coxiella. Here the thing is that since the lady had traveled from Middle East, we need to think about MERS-CoV as well. So basically, this lady has to be isolated, and the multiplex PCR platform was adopted. And this turned out to be a case of influenza, but suppose it had turned out to be a case of MERS-CoV, then a lot of healthcare workers would have got exposed. So that is the problem. So this outbreak monitoring unit has two arms. One is the diagnostic arm, and second is the IPC. It's the infection prevention and control arm. And we need to focus on both these arms equally. So this is how the OMU works. There is a clinical alert, then there is an OMU alert, then isolation IPC measures are adopted. We use this multiplex PCR platform, and if it turns out to be something like influenza, etc., the alert is withdrawn. Another case is a 21-year-old who presented from Middle East, and he had fever, hemorrhagic rash, ARDS, myocarditis, AKI, hepatitis, DIC, and probable encephalitis as well. He was working in Muscat in a car showroom and returned to Kerala following symptom onset. You can see the hemorrhagic rash and the blood is actually coming through the rails tube. He was in DIC and hemorrhagic rash sort of things. Actually, this turned out to be, you can see these are the DDs, hemorrhagic varicella, because he had contact with varicella while he was in Middle East, but we did not see, at the time admission, we could not see any vesicles because he had come around 5 days after the onset of this rash and all. Expanded dengue syndrome is a possibility since he is from Middle East. CCHF, Crimean Congo hemorrhagic fever, is a possibility. Ebola, Marburg, rickettsiosis, meningococemia, Lassa fever, etc. So what we did is, since we are not able to come to a diagnosis, we have to isolate the patient, take all the precautions, and then using the PCR platform, it turned out to be a case of hemorrhagic varicella itself. This is a case of a 9-year-old girl from Palod. That is, Palod is near the forest fringes in Kerala, in Trivandrum. She presented with fever of 1 week duration, followed by recurrent episodes of seizures and presentation. Child had leukopenia, thrombocytopenia, transaminitis, ARDS, myocarditis, and encephalitis. So clinical diagnosis was expanded dengue syndrome, but all the investigations for dengue turned out to be negative. And interesting aspects in history were a poultry death 3 weeks back, and monkeys and wild hogs near our house, etc. So these were the DDs considered: expanded dengue syndrome, viral encephalitic syndrome, scrub typhus, and KFD. So KFD is important. That is, if the first week the patient is presenting like dengue, and towards the end of second week, if the patient is presenting with encephalitic syndrome, then we need to consider KFD in areas which are endemic to KFD, like, say, the Nilambur area, Wayanad, etc. So the KFD has not been reported from Trivandrum, but I think around 5 to 6 years back, we had monkey deaths in Palod due to KFD. So monkey deaths is a harbinger of transmission to humans. So in this case, all the investigations turned out to be negative. And, when we think about outbreak response, we have a reactive response like what we do in Nipah. It is, you diagnose Nipah and then we go for the control measures. Then the preemptive response means that, we set in an epidemic intelligence in place so that you are able to pick up the first case at the earliest. Like COVID was a success story in that response. The first case was a person who was in quarantine. And just like monkeypox, also the first case was picked up without transmission to others. So this is an example of mpox. And following this, we did issued guidelines like any patient who is coming to Kerala from Middle East, etc., and who present with fever and rash or lesion within 21 days, we need to rule out mpox as well. And this is what happened in 2022 in Thrissur. So 19-year-old boy working in Dubai returned to Kerala with history of fever of 5-day duration with inguinal abscess. He had just an abscess. He developed headache and seizures on day 9, expired by day 12. This turned out to be a case of mpox encephalitis, and we have around 40 cases of mpox reported in the state over the last 4 years, and all of them except 2 were imported from Middle East to Kerala. So this is the only boy who died. And it was due to mpox encephalitis. We are not sure whether it is mpox encephalitis or some autoimmune encephalitis triggered by mpox. But unfortunately, this boy died, and this actually prompted us to revise the state guidelines. State guidelines are based on the national guidelines, which said that any patient with fever, myalgia, with rash were returning from other countries where the mpox transmission is going on, and if they are developing within 21 days, this 21 days is the cutoff period. They are supposed to do this. This patient never had a rash; he just had an abscess, right? So WHO guidelines say that rash, abscess, then genital any sort of lesions, oral any sort of lesions also should be considered as pointed towards mpox. And that case got published, important case of fatal encephalitis associated with mpox infection in India. And coming closer home, so this person who's from Assam, he was working here for the last 6 months, a 23-year-old gentleman. He presented with fever, myalgia, headache of 4 days duration, epistaxis, ecchymotic pack, plus necrotic lesions over face, trunk of 1 day duration, dyspnea 1 day duration. And basically, diagnosis made was a tropical fever syndrome with ARDS, myocarditis, DIC, and pseudohepatorenal syndrome, the classical presentation of leptospirosis. So he presented to us within 4 days. He was actually having these sort of necrotic lesions over the face. You can see multiple lesions. So someone thought it is a case of mpox and referred to us. So mpox usually don't present like this, but these DDs were considered since he is from Assam and all, and we were not really sure about his travel history and whether he was in Kerala over the last 6 months, etc. We are not sure. So we considered CCHF as one possibility, rickettsiosis other than scrub, because scrub usually we have only one scar. Meningococcemia was also a possibility. Anthrax was considered. So the Wheel syndrome, everything fits in with Wheel syndrome. The only oddity was, the multiple necrotic lesions, as in this case, is very, very odd. He was referred as a case of mpox, but based on our experience, it's not a case of mpox. And the patient died within, say, 12 hours of, he was on ventilator and died within 12 hours. And from autopsy, all the samples were positive for lepto. Lepto PCR was positive. So you can see that even lepto can present with necrotic lesions like this, and monsoon season, intermittent rains, etc. We are likely to see a lot of atypical manifestations of leptospirosis as well. And coming to another scenario, it's very, in Trivandrum area, a lot of cases were reported, Kannur, etc. A 26-year-old pregnant lady at 14 weeks gestation presented with fever, headache, maculopapular rash, arthralgia, non-purulent conjunctivitis, and lipedema. NS1 and dengue PCR done during first week were negative. IgM ELISA done on day 8 was positive. So what is the probable diagnosis here? So the thing is that we know that Kerala has Zika circulation as well. And Zika can be diagnosed only through the PCR. Zika being a flyvirus like dengue, there is a cross reaction. So you can see that the Zika will be like a milder form of the chikungunya. So any patient with fever, headache, rash, arthralgia, non-purulent conjunctivitis, please do think about Zika as well, especially when the dengue NS1 and PCR is negative and dengue IgM is positive in the second week, because Zika also the dengue IgM, because the cross reactivity will be positive. And the state guidelines clearly mention that any pregnant lady with fever and rash, we need to rule out Zika as well. So to identify Zika, we need to do the PCR from the blood, the urine, etc. And all of us, we had a session by IMA itself. Dr. Raji, they had talked on the hantavirus. So diffuse alveolar hemorrhage like this, we always think about leptospirosis. But in certain cases, the leptospirosis PCR is negative. So in such scenarios, should we think about hantavirus infection in Kerala as well? So we do think about that, but not we send the Hanta IgM, PCR, etc. But has come out to be negative. But recently there was a publication that is, I think, last year December. This is from Ernakulam, where they checked the anti-ortho hantavirus antibodies in febrile patients in India, means from Kochi. So in 16% of febrile patients, they identified this ortho hantavirus IgM positivity. That clearly shows that hantavirus also could be a possibility in patients who are presenting with secondary syndrome or the thrombocytopenia or the hemorrhagic manifestations with renal syndrome in the Kerala as well. It could be an emerging infection. And this case had come to us in Trivandrum around 5 years back. A 16-year-old boy post-renal transplant had presented with fever, myalgia, headache, and maculopapular rash over the trunk. On day 5 of symptom onset, he developed seizures, altered sensorium with asymmetric flaccid cautery paresis. a clinical diagnosis of an encephalitic syndrome with anterior hornsel involvement was made. The CS of all these investigations, VCRs, were negative. And this turned out to be a case of West Nile. So this West Nile encephalitis in the post-transplant patient. So we know that West Nile is a problem in Kerala as well. A lot of cases have been reported from certain areas of Kerala. Now an outbreak is going on in Ernakulam. And interestingly, this study was published in January this year from NIV Alappuzha. So it is a community-based focal zero survey for West Nile virus infection following a surge of cases in 2024 in Kerala. And you can see the seropositivity rate. In Kozhikode, it was 24.7%. So basically, the study population was, in areas where the West Nile were identified, the family members and the other people in the village. There they checked this serum for the West Nile antibody positivity. So Kozhikode, the positivity rate was 24.7, Malappuram 29%, Thrissur 34%, Ernakulam 61%. So what we need to understand is that in West Nile fever also the neurovirulence occurs only in around say 2 to 3%. So the majority of the patients will be having asymptomatic infection or a exacerbated fever sort of presentation. We also know that in dengue around 80 to 90% are having mild infections, right? A lot of them have asymptomatic infection, others will be having mild clinical manifestation, and only around 5% will present with severe dengue sort of presentation. So that is true with West Nile fever, Japanese encephalitis as well. So when we are looking at the seropositivity, it is very high. But that does not negate the threat it causes, because the neurovirulent West Nile, there's West Nile encephalitis, etc., the mortality as well as the morbidity is quite high. And another thing we should be on the lookout in Kerala, especially in Alappuzha, Pathanamthitta, the Kumaragam area, is the avian influenza. We know that the avian influenza has crossed over from the birds to the mammals, and last year around 15 cases have been reported across the world. This means it has spilled over to humans as well. 2 cases have been reported from India as well. Suppose any person with admitted in any of the hospitals in Kerala with severe acute respiratory tract infection, and if there is any contact with the poultry and the influenza A is coming as positive, but we are not able to subtype it into H1N1 or H3N2, that is a scenario where we have to think about avian influenza. It is H5N5 or H5N9 sort of thing. It is influenza A is positive, but we are not able to type it into H1N1 or H3N2, and if there is a contact with birds, so we need to think about avian influenza as well. And now coming to the most important aspect, how to identify these emerging infections. The pre-test probability is the key. So we need to select the right test based on the epidemiological factors, very, very important thing, the clinical features, the anthropological factors, immune status, host susceptibility, and the test characteristics. Because, usually the BioFire and our real-time PCR panels does not include Nipah per se. So basically, if you're having a suspicion of Nipah, it's very difficult to have a suspicion of Nipah. So basically, any encephalitis in Kerala, if you don't have a diagnosis, it will be better to roll out Nipah as well. And in any case of ARDS also, if you are not having a diagnosis, we need to roll out Nipah. That is actually very difficult because you need to do a lot of testing to identify that. So basically, coming to the preparedness from a clinical perspective, so for emerging fever, we should not be preparing for Nipah or Ebola like that. So emerging, we are having COVID circulation now, we are having influenza circulation now. The 59-year-old lady who died due to Shigella in Malappuram, she was having acute coronary syndrome as well. So basically, we need to know our diabetes and hypertension status and keep them in check. Optimize our BMI, optimize the glycemic status, control the comorbidities, focus on the 3 C's and ventilation. 3 C's means in close contact settings, crowded places, etc. So we need to ensure that all the vulnerable people, like the immunocompromised elderly, should be using masks. And obviously the vaccination, like the flu season is going on, etc. All the people who are at risk of developing complications must be taking the flu shot. So thank you very much for the opportunity.
Thanks a lot, dear Aravind. Actually, enlightening on emerging fevers and evolving solution is not a easy solution. It's a big task, and Dr. Aravind has done in a really fruitful manner, which everyone can understand. There will be some questions. Please stay back for a few minutes too. See, our Dr. Altaf has some technical problems with which he cannot join. So, Dr. Rajmohan sir, who is actually Southern coordinator of the IMA Public Health Committee. And more than that, actually, it was a pleasant surprise for me too. I know that he is an eminent, scholar, researcher, everything. Whenever we speak, he speaks on research. Prashant, we must do something more on research, with which I am passionate about. And this Rajmohan sir is in MD Community Medicine too. MD, apart from MD Pediatrics. Sir, it gives me immense pleasure to invite you to address the gathering on the, emerging medical issues, particularly fevers. Today now we have reported cholera, and there are issues. And what are the evolving solutions from a community medicine point of view, as well as a researcher's point of view? And do it needs, input on your favorite topic, research by every clinician? Over to you, sir. Rajmohan sir, kekavo?
Am I audible, Prashant?
Yes, sir, very much, please.
In fact, this is always a topic which needs constant attention. But unfortunately, when the monsoon comes, only everybody is being alert and into action. And for any health system, during the quiescent period is the maximum planning and activity taking place. Because when the epidemic or pandemic comes, we should be ready with it. In all means. For example, the most crucial thing is human resources. The buffer stock of human resources is a must. But disaster, everybody shun things to other departments. For example, there is a disaster management authority, and usually coordination is not that as expected. I'm not talking about any government, every government. This is the matter. The professionals are not given the freedom to act, and that we have seen all these things. Now we are expecting a change, because even for the final authorities there are advisors which are our own brethren. So we hope things will be now better. So coming to the issue of surveillance is collection of data for action. We are collecting data, but whether our systems of data collection are relevant, are appropriate to our public health priorities, and the mechanisms are foolproof, these are all the important things. For example, Dr. Jacob John came here with the suggestion of, he is a very reverend, all of you know him, reverend public health expert and microbiologist. He came here with the two suggestions. That was when Umanjandi sir was the chief minister. I was also in the advisory, state level advisory academic think tank, very close to the chief minister as well as the health minister. Jacob Jones sir came with two suggestions. One was for Public Health Protection Agency. The other one was for a method of data collection of surveillance, which was a very peculiar thing. He wanted to introduce postcard method of surveillance. Of course, I don't underestimate any method if it is innovative, because always alternates are, if work, it is always good. So these two things, I remember a lot of meetings have been happened, and at that time there was a hepatitis A outbreak. Because of that, people were alert. That was in Kottayam. You may be remembering that. And Shanai sir, myself, everybody was in action. And afterwards, the fever death, media wanted to make hypes about fever deaths and fever surveillance. And IDSP, if you go, there are plenty of voluminous data about IDSP, infectious disease surveillance program. Actually, IDSP program is a national program. It is a national activity. And the integrated means there are many integrations. One integration is integrated in terms of technology. Integration in terms of human resource management. For example, medical education department with DHS. Integration in terms of non-communicable disease and communicable diseases. So the IDSP platform is a very broad platform, and we are supposed to make diseases of local priority in addition to the 14, at that time it was 14 diseases of national priority. Now it might have been definitely changed. So the local priorities is our, for example, scrub typhus. It is not a priority for all states. We can make our own. Melioidosis. It is not a priority for all states. Tamil Nadu, it is a priority. But in our place also, after flood only melioidosis comes. Similarly, the disease, what I mean to say is that planning is more important than operationalization. So if it is done, planning is done proper, things will work. Unfortunately, that level there are a lot of loopholes. So IMA is taking steps for revamping surveillance, re-energizing the surveillance platform through a new paradigm shift of leadership by medical persons. I am saying that the medical person should, that is the best model is in UK model, where the NHS, it is all governed, the governance of health system is by clinicians and medical people. So then the question comes, because we are not capable of doing that, our competence is many a times doubtful, because one of our health secretaries always used to say, you are still in a Freudian anal phase, because you always shun things to the higher level, secretariat. But I think, unfortunately, our Ramesh sir got a very short period for DHS. He couldn't show his leadership and competence as it was expected by all of us. So that was because of his health problems and those things. But sir is there with us for our leadership in IMA and also in national level. We are lucky about it. I was incidentally remembering about his active period as DHS. That is just a passing comment. So my only request is that the medical people, the medical team should take leadership. So the medical leadership should decide policy, and we should do not only policy advocacy, but we should also do policy interventions for strengthening our surveillance platform, because the only answer is surveillance. Because Arvind has rightly mentioned this. Fever surveillance is a point of care testing and just-in-time learning for decision making. And surveillance, as you all know, data collection for action. So unless there is action and feedback from action for system strengthening, there is no point of surveillance. So that is all what I want to tell you. Please join IMA as the leadership initiative and strengthen our brotherhood. Thank you.
Thank you very much, sir. Actually, in fact, you have thrown light into the in a big arena, vast arena, and you have made many things very clear. And in fact, Ramesh sir, again, the contribution of Ramesh sir is again, we could mention it again. And the program, the talk is open to discussion, and we have Dr. Aravind and Rajmohan sir and eminent other faculties. Include Marthandapalla sir also has joined, I think. Marthandapalla sir.
Recording in progress.
Marthandapalla sir, can you hear me?
Yeah.
Sir, please share your views.
Yeah, nothing more to say other than that Aravind excellently presented the topic, and as usual. And another great thing is he is always available for a second opinion even from the private sector whenever we have issues. So I particularly congratulate him and thank him for the dedication he is showing. And our public health committee is become timely active. Pradeep and Altaf, Rajmohan, and others are very active. And we are confronting with newer and newer infections every year. And even the listing of them itself becomes a difficult process. Ondas and this and that thing and all. So many things are there. And HIPAA again has come up. So a public health alert definitely is very essential. Masking, hand washing, and going back to the old period, we may have to do that. And I'm sure that a very competent committee is taking care of the public health issues and coordinating it with the general practitioners. Job Prashant is excellently doing it. I wish you all the best. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you very much, sir. Pradeep sir, can we go for interaction, right? Huh?
Yeah. There are some questions in the chat box, so Prashant, you can just read so that Arvind can answer those things.
See, there is one question: where to send samples when suspecting for Shigella?
Actually, the Shigella culture can be done in any microbiology lab, but majority of the cases are being diagnosed with PCR, which obviously has more sensitivity than our culture. So the PCR can be done by the region public health lab can transfer it to the state public health lab and do it. And in Trivandrum, Kollam area, our IAB can also do the thing. The problem with the PCR is that we will never come to know about the culture and susceptibility, the antimicrobial susceptibility. We will never know.
Actually, the other questions I saw Dr. Arvind, took pain to reply to in the chat box itself. There is one other question. See, the fevers comes and goes, and new illness comes. Will the universal precaution help in its real sense?
Sir, actually, the thing is that like we all work in may it be in the government sector or the private sector. All of us work in very crowded environments, and the chance of us picking up, say, a SARS-CoV-2 or influenza is going to be much, much higher than us picking up Nipah or Ebola. So our focus always has to be on the respiratory infections, and we know that even for healthcare workers, means depending on the host factors, sometimes SARS-CoV-2 and influenza can lead to severe manifestations. So definitely, all of us should be wearing at least a triple layer mask while in the hospital, and in the ER as well as the wards. It is compulsory that we should insist that the bystanders also should be wearing the mask. We know that the outbreak is going on. A lot of people, whenever we are testing the SARI and ILI now, 50% is turning out to be COVID now, and 50% is turning out to be influenza. Last year itself, around 60 people in Kerala died due to the SARS-CoV-2 infection. The only thing is that they were having all these comorbidities, the CLD patient, CKD patient. Last week, we had around 16-year-old girl with lupus nephritis with pulmonary hemorrhage. Unfortunately, she developed COVID-19 also, and she succumbed to the disease. We had a 140-year-old person who was in ventilator for, say, 1.5 months due to COVID and died. So COVID is a reality, and we should be protecting ourselves. So standard precautions means, using the triple layer mask always, sticking on to the 5 moments of hand hygiene. And if we think that our hands are breathed, we need to have gloves as well. So that has to be, standard precaution means irrespective of knowing the diagnosis of the patient, we should be using it all points of time. Sometimes, we have to upend our precautions. That is the transmission-based precautions based on the, when we know the diagnosis. But if we practice the hand hygiene and the masking, to an extent, we will be protected against all sorts of infection. So airborne infections may not be prevented by our triple layer mask, but it definitely cuts down the inoculum load. So in majority of the things, the inoculum load does matter. If the viral load to begin with is low, the chance of we get more time so that our antivirals etc. can access. So standard precautions we should be adopting always.
And then another thing is, again, an increasing trend of, subscribing to antioxidants. Yeah, vitamin C, loading with vitamin C, people are doing it. And will that help in any means?
Actually, we don't have any evidence showing that these sort of things will work. I think if Altaf sir had been here, he will definitely say that we should be focusing more on the preventive aspects. So if you're looking at, what has been happening in Kerala over the last 3 years, all the waterborne diseases, our water quality has gone for a toss. Even, the rise in acanthamoeba, we can say that our well chlorination, all those things, there are issues. So, hepatitis A, the numbers are so huge. Enteric fever is coming up like anything. And now the Shigella outbreaks in all parts of the state. Cholera, it's just a point outbreaks as of now. But this is going to be the state of affairs, and if we are not paying that much attention to the water quality, and another aspect is that we have around, say, 30 lakh, just workers in our state as well, who are coming from areas where all these things are very, very prevalent. So if we are not very concerned about the water quality, definitely these sort of Shigella outbreaks and waterborne diseases will become the new norm in Kerala.
Is NGS for CSF testing available in government labs? Where?
NGS, actually, our public health lab has started NGS. Means last month, they have started NGS. It's on an experimental basis. It's not like we are going to do all samples. They're doing a trial run of NGS, and probably, once their algorithm, etc., are finalized, maybe in 2 to 3 months' time, means they might also start doing this CSF NGS. As of now, only the multiplex PCR and the real-time PCR are being done. NGS, we do have access to that in the BS lab.
Okay. One more point, even though it is time, people are, encouraged vaccine for, influenza. But many a time when the vaccine comes, the event is over. The next, the subtypes comes. Is it true or is it still recommendable?
Actually, for WHO recommendation is for everyone to take the yearly the flu shot, and for the southern hemisphere, northern hemisphere, means every year they come out with the recommendation. The only good thing is that from this year onwards, we require only the trivalent one, because influenza B Yamagata is not in circulation from 2020, so we require only the trivalent one. The thing is that some of us, definitely the immunocompromised should have this vaccination. The elderly should have this vaccination. Among the so-called immunocompetent, some of us, when we develop this the flu-like illness, we may be having this might develop some severity, right? So maybe having this cough for say maybe 1 month or so, or exacerbation of asthma, etc. So that category also should receive this influenza vaccination.
Thank you. Is it necessary to plate the stool sample or for Shigella within 20 minutes for good result? Will this cause difficulty in remote areas?
I'm not sure about that. Means it might include the culture. So the culture, majority of the cases, culture is negative, because by the time the patient reaches the tertiary care center and the samples are being taken from there, they would have received some antibiotics. So that is the important thing. The PCR, that's not a problem with PCR. So one thing that we need to keep in mind is that quinolones are not going to work. So 95% of the Shigella in the state is resistant to ciprofloxacin. So ciprofloxacin is not going to work at all. That is something that everyone should keep in mind.
Doxycycline.
Ciprofloxacin won't work.
Which will work?
Cefixime, we advise actually Cefixime. Even for Cefixime, ceftriaxone, the resistance is 25%. So if the patient comes in shock-like stage, in our pediatrics, they start with meropenem, and once the culture comes, they will de-escalate. Okay. So if the patient is stable, etc., you can go with Cefixime. Quinolones will never work. That's the only thing we can say.
The traditional stool RE, seeing a lot of puzzles there, clinical side examination, do you recommend, at least in the periphery?
Yeah, we can actually, if things are not available, definitely a stool examination also will help us. The presence of RBC and all those things will actually help us, where this dysentery and whether the patient requires antibiotics. So majority of the ADD cases does not require antibiotics, just ORS and hydration will suffice. But one thing we need to keep in mind is that, based on that excellent study from the Calicut Medical College, even for people who have developed Shigella encephalopathy, around 10 to 15% only had dysentery per se. That is also something we need to keep in mind. Suppose there an outbreak is going on and a child is coming with say encephalitis or myocarditis and vomiting and all, and just the absence of diarrhea does not rule out Shigella encephalopathy. These are the things that we need to keep in mind.
Dr. Roy Chandran, Dr. Roy Chandran is the state secretary.
Dr. Roy Chandran, our beloved state secretary, is available online. I invite him for his remarks.
No remarks. Just question answer time.
You can ask the questions directly.
Yeah, I've sent some questions. I've sent 2 questions in the chat box.
Dr. Roy was asking, could climate change be contributing to the increasing incidence of endemic infections like Shigellosis in Kerala? And another thing is a very pertinent question, is Shigella becoming a next major antimicrobial resistance threat after maybe MDR-TB or resistant typhoid?
Regarding the climate change, I'm not sure, because wherever the health workers are going on and conducting these outbreak investigations for Shigella, they are identifying breaches in water quality. So, if the water quality is a problem, means, the fecal contamination is happening. So that is the reason for Shigella. I don't know whether climate change is directly linked with that. I don't know. Regarding the second aspect, antimicrobial resistance in Shigella. So, like every year, the state publishes the antibiogram, and in 2021, 2022, etc. For Enteric fever, we had only around 50 isolates, etc. But last year, we had more than 100. And the important thing is that we are having data only from 59 centers in Kerala. Okay, and the numbers are actually coming up. And in Shigella, the quinolone resistance is universal. Ceftriaxone resistance is say 25%, and azithromycin resistance is 15%. So if you are not really careful about the use of antimicrobials, just like MDR, TB, resistant typhoid, etc., the Shigella also might become an issue. Ceftriaxone resistance is also a major issue, right? So basically, that is a problem. Yeah.
Yes. Then another question, it is a bit specific question. Can we give priority for epidemiological diagnosis rather than clinical diagnosis in case of recent Wayanad episode?
Actually, the thing is, if you are having there is a clustering and one case is positive, others are, or for all practical purposes, others are also considered as shigellosis.
Okay.
They will come under the probable category, that's all. So one is a confirmed, other is a probable, but containment measures remain the same for both.
Rajmohan sir, anything to? Sir, Ketuda. Rajmohan sir, Ketuda sir.
After that, we can conclude, no, Prashant?
Yeah. Rajmohan sir, there is some technical problem. So currently we are using any specific treatment in severe COVID.
Unfortunately, remdesivir is in the news, right? So remdesivir, we don't have access to remdesivir. The antiviral that we used to use for severe COVID was remdesivir. Now we are not using antivirals. We are relying on patients who are having hypoxia. We are using steroids and anticoagulants. So majority of the cases that will suffice, steroids as well as anticoagulants. We are not using any antivirals now.
Thank you very much. Dr. V.G. Pradeep Kumar sir, anything to add?
No, actually, that was excellent presentation by Dr. Aravind and contributed by Rajmohan sir. And this is an initiative which now we will have to take it to public also. Similarly, some questions as well as we can have some Malayalam PowerPoint presentation, and we should have some put in the public domain as well. I request the help of Dr. Aravind as well as Rajmohan sir in such initiative. And thank you, Dr. Prashant and CGP for this coordination. And on behalf of Public Health Committee, I thank Dr. Aravind and Rajmohan sir for their support.
Me to join you in thanking you all, particularly, as helping Dr. Arvind's presence, his commitment. We are deeply grateful to you, dear Dr. Aravind, and we'll be standing firmly with you. You go ahead with your mission. We are firmly with you all. And may I thank you all, particularly the leaders and the eminent leaders like Mathanabala sir and Menon sir, our beloved State Secretary is staying with us. That means that IMA is giving that much priority to the topic. And so we are grateful to the leaders, and we are grateful to all other delegates who have attended this program. May I once more remind you, every Thursday at 8 p.m., we are discussing relevant clinical issues under the banner of IMA College of General Practitioners. You can use the same Zoom ID, Zoom link, and passcode which you have used today. Please do join, and please also share your valuable opinion and how IMA should intervene more. And your suggestions are always welcome. Together we achieve more. Thank you all. നിങ്ങളുടെ എല്ലാവരുടെയും പ്രിയപ്പെട്ട ഈ സമയം ചെലവഴിച്ചതിന് വളരെ ഹൃദയത്തിൽ നിന്ന് ഇന്ത്യൻ മെഡിക്കൽ അസോസിയേഷന്റെ പേരിലും എൻ്റെ വ്യക്തിപരമായ പേരിലും പബ്ലിക് ഹെൽത്ത് കമ്മിറ്റിയുടെ പേരിലും ഒക്കെ ചേർത്തുള്ള നന്ദി രേഖപ്പെടുത്തുന്നു. എല്ലാവർക്കും ശുഭരാത്രി, സുഖനിദ്ര. താങ്ക് യു വെരി മച്ച്.
Thanks.
Good night.
Good night.